So this is part 3 of the kidney disease PowerPoints, and this is specifically talking about dialysis. So we'll talk about hemodialysis, peritoneal dialysis, and some of the CRRTs. So what you want to do is keep everything very simple, all right? You know that the patient, if they're needing dialysis, it's either an emergency, maybe they had AKI, and their potassium levels are incredibly elevated, it's a dangerous situation. Or it's potentially somebody who has end-stage kidney disease and they just need to be getting dialyzed on a continuous basis, right? So the problem is the patient has too much toxins in their body and we need to clean their blood. That's it. We need to clean their blood. So we need to get rid of things like potassium, too much sodium, too much phosphorus, too much fluids, right? All the things that normally our kidneys are able to get rid of for us, to keep us, functioning properly. And in order to do this, we are going to need an access, right? So if it's hemodialysis, we're either going to need a graft or we are going to need a fistula. We prefer a fistula, right? An AV fistula. If that's not possible, then we're going to have a graft. And if that's not possible, then we're going to use a catheter. If for whatever reason the patient cannot tolerate hemodialysis and maybe they want more autonomy, they want to be at home, so maybe potentially for that patient we're going to be doing things like peritoneal dialysis, okay? But essentially all we're doing is trying to get rid of toxins in our body. So how are we going to do that? We're going to use the principles of diffusion, osmosis, and ultrafiltration. That's what we're focusing on. So in terms of the nursing care, it is making sure you're assessing your patient before they get dialyzed. So things like getting a baseline, getting their vitals, weighing them, all of that you're going to do. Some institutions, because usually when patients get dialyzed, their blood pressure actually bottoms out and it's very low. So in some cases, they will tell you to hold the blood pressure medications because normally the patient will get dialyzed and then their blood pressure is going to be very low. So depending on how high the blood pressure is, they may actually tell you, what, don't even give them their BP meds because after they come back from dialysis, their blood pressure is going to be low anyway. And actually when you go to dialysis, everything that you take is going to be cleaned out anyway. So in some places they will probably say don't even give them any medications because if you give them vitamins, etc., they're going to hemodialysis and everything gets cleaned out. So you have to really just find out what your particular institution is doing. Okay, so with dialysis, all we're doing is we're moving fluid and molecules across a semi-permeable membrane from one compartment to another. So once a patient is getting dialyzed, it means that we are doing this in order to correct fluid and electrolyte imbalances and basically remove waste products, right? Because the kidneys are no longer working for us. Patients can also be dialyzed when they have drug overdoses as an emergency. And obviously for the drug overdoses, you don't have time to do a fistula or even an AV graft. So for sure, for those types of things, they're going to be putting in a catheter. So they'll be using either your internal jugular vein or even your femoral vein in order to gain access. There are two methods of dialysis available. So there's peritoneal dialysis and there's hemodialysis. So if a patient needs to be getting dialysis, like we said, the patient's uremia can no longer be adequately treated conservatively. Their GFR is less than 15 milliliters per minute, and really the nephrologist is the one that's going to determine that, all right? And uremic complications, we've discussed what those look like. We've discussed how every single system in your body is affected. Make it impossible to just leave the patient like that. They have to get dialyzed. So we're doing dialysis for a lot of these patients with end-stage renal disease because there is a lack of donated organs. Some patients are physically or mentally unsuitable for transplants. If you have patients that are drinking all the time, not paying attention to their diet, even if you give them a new kidney, they'll go back to their old ways anyway, so it might not make a difference. And some patients do not want transplants, right? So they would prefer to be getting dialysis. So this, I actually adjusted this slide a little bit so that it would flow better with audio. So these are the general principles of dialysis. You're getting diffusion, which is movement of solids from an area of greater concentration to an area of lesser concentration. So that would be the too many solutes that we don't want, like things like the potassiums and the sodium, those types of things. There's too much of that stuff, so it's moving over to the area of lesser concentration. And then we're also dealing with osmosis, right? So with osmosis, it's movement of fluid from an area of lesser concentration of solutes to an area of greater concentration. So the glucose in the dialysate creates an osmotic gradient to pull fluid from the blood, right? So you know that fluid moves from an area of lesser concentration of solutes to an area of greater concentration. So that's that mechanism that's happening there with osmosis. And then there's also this process known as ultrafiltration, and this has to do with water and fluid removal. So this also happens when there is an osmotic gradient or pressure gradient across the membrane. So specifically with peritoneal dialysis, in order for them to get rid of all that excess water that the patient has, they'll put a whole bunch of glucose in the dialysate basically. So it's still doing the same thing. It's pulling all of that water out, and then we are getting rid of it. For hemodialysis, they're using a pressure gradient accordingly. So it's between the blood and the dialysate. So depending on what the pressure gradient is, if it's positive in the blood and negative in the dialysate, the excess fluid moves into the dialysate and then is basically excreted out. So there's some type of pressure there that's happening. And they have alarms. I don't know if any of you are familiar with hemodialysis, but they have alarms that lets them know what the proper, pressure gradients should be, and all those types of different things. So essentially, at the end of the day, we want that excess fluid to be going into the dialysate. So this is just a picture of what this may look like for osmosis and diffusion across the semi-permeable membrane. So you're seeing here some of these funky things like sodium, urea, potassium, basically, moving into the dialysate, right? So there's too much of it in the blood, and then it's moving into the dialysate. And what you need to remember about the semi-permeable membrane is that it's actually made up of like a whole bunch of different layers. It's not just one individual layer. It's like a whole bunch of different individual layers, and it's in dialysis, the process can be maybe 4 to 6 hours depending on the orders. So it can happen pretty quickly, the exchange that needs to happen. And some patients tolerate it really well, and some patients do not, because remember, you're getting rid of all this junk, and if you're doing it too rapidly, your patient might actually not feel well. They may, complain of muscle cramps, for instance, or they may feel dizzy. All of those weird things may be going on. And then the dialysate is very much individualized. It's not going to be the same for everybody. So it also has some good stuff in there that maybe the patient may need. So maybe your patient needed things like I don't know, maybe calcium, for instance. So then the patient would be getting some of that into the blood, right? So all of this are some of the different things that may happen in dialysis. Peritoneal access, when we're talking about peritoneal dialysis, is obtained by inserting a catheter through the abdominal wall, and the technique for catheter placement varies. Usually there's some type of surgery that happens. You can use a catheter right away if you're giving very little volume exchanges, that's fine. But in most cases, they have to wait until the site has actually healed. And that may take as much as 2 weeks, I think is what your book was saying. Aseptic technique is king. The biggest complication that we can worry about is peritonitis. We've covered peritonitis, and you know how bad this can be. So this is a picture of what peritoneal dialysis may look like. I do need you to be familiar with the bags and how they look like, right? So you have, this is the dialysate basically solution that's coming in, right? So you have, this is a catheter over here. So it's going to have 2 ports. So one is to receive the dialysis solution, and then the other one is basically to drain the junk after they are done, right? So depending on the orders, maybe it's a 2-liter bag that you have to hang. So remember, everything is happening in the peritoneal cavity. You don't want your dialysis solution to be too cold. Ideally, you want to have taken it out from the wherever they keep it. Make sure it's at least at room temperature. You don't want it to be too cold because it can actually cause contraction. If there's contraction, the exchange that needs to happen in the peritoneum is not going to be very good or as efficient as you would like it to be, right? You're not warming it up by putting it in a microwave, because in a microwave you can never tell what the temperatures are. You just want to make sure that it's ready, room temperature, and then the patient can use it. So this is going to be on a pole. You're going to put it up there, and they'll tell you how long to infuse it into the peritoneum, right? So there is a catheter here. So you open it up, and so maybe they said over 10 to 15 minutes, let's say. So you're going to let that all of that go in, right? And then you're going to clamp this off, right? And there's a pole up here. And then there will be an amount of time that they want it to dwell, right? So the part here where you're infusing it, that's known as the filling time. So you fill that in, that's the fill. And then clamp it off, you let it dwell. So it's going to sit in there depending on however long the doctor has ordered. So that's the dwelling period. And then when that time is done, you are going to open the clamp for this bag that's down here, and you just basically just let it come right out into the draining bag. So this is the drain. All right, so fill, dwell, and then drain. The output really should be kind of straw colored looking, nothing funky. You're really paying attention to what is coming out. It shouldn't be cloudy, and so it shouldn't be dark. It shouldn't look funky. If it does, you want to get a sample and send it for CNS to make sure there isn't an infection. If the catheter is new, the first couple of exchanges, probably like in the first 2 days, they're probably going to be a little bit bloody and blood tinged, and that's perfectly normal. But if the patient has had the catheter in for a while and all of a sudden it's bloody, then you're worried that maybe the patient is having peritoneal bleeding, or maybe something that even perforated. So those are things that you have to investigate. If it's very sudden, it's very new bleeding, after the patient has had this catheter in place, then you just want to monitor that a little bit more. All right, so this is what your catheter may look like. So these are the 3 phases of PD cycle, right? So manual we're talking about here. So the infill, so it could be 2 to 3 liters over 10 minutes. The dwell, also known as the equilibration, anywhere from 20 to 30 minutes to 8 hours. So the orders will vary for the patient. So how long do they want it to sit there? How long do they want the exchange to happen? So and you're using the peritoneal cavity once again. And then the drain, you just empty it out and let everything come out. So usually they want over 15 to 30 minutes. And then you repeat it. So some patients, maybe all they need is a 2-liter bag. And if they're lucky, that's it for that particular time frame. So maybe they might need to do this maybe 3 times a day. But let's say your patient, was really good with their diet, water intake, and they're lucky. They only needed that one treatment and they're good. But once again, remember the kidneys are always functioning 24 hours. So that would probably be like a super perfect patient. But most patients would need more than one exchange for sure, 3 to 4 times a day, depending on how much junk they have in their body. And yeah, so there's variations in how much they can put in, and times, how long the dwell is happening, is the major one in terms of how long they can do it or how short they can do it. So sugar, once again, is an osmotic agent that's put in the dialysate to basically pull out some of the junk, especially the water. Okay. They have what is known as an automated peritoneal dialysis, APD. So just know that this one is out there. Apparently this one allows you to get PD at night, right? And it's a cycler that's controlling the fill, the dwell, and the drain phases. And then there's alarms and monitors for safety as well. And then they also have this continuous ambulatory peritoneal dialysis. So this is another one that they can do continuously. Basically, you're doing these exchanges 4 times during the day. So just know that these are out there and they can happen for the patient. That's the automated peritoneal dialysis. Main complications from peritoneal dialysis. So the big one I mentioned was the peritonitis. So it's all about infection. Things like redness, tenderness, and funky drainage that you're looking at. So it's foul and it's cloudy. So treat that with antibiotics. The main reasons for peritonitis is because somebody's not using aseptic technique, and that is really why this is going on. So you already know what peritonitis is going to look like. So these are some of the manifestations here. So things like abdominal pain, rebound tenderness, cloudy effluent. So effluent is the stuff that's coming out, right, in the drainage bag. And you're seeing things like increased WBCs or bacteria, and then even having a temperature. You're going to be seeing GI manifestations. So obviously you're going to treat all of this with antibiotics. And if they get too much of the peritonitis infections, they can end up getting things like adhesions as well. They can get hernias from increased intra-abdominal pressure from the dialysate. For that, they can do a hernia repair. They can get lower back problems, and this is from the intraperitoneal infusion. Increases in pressure, and so for this they can give orthopedic binders. So this is for the back. The back is a problem. They can give orthopedic binders, and they can do some exercises to basically increase their back strength. Some of the pulmonary complications apparently happen a lot because of the longer dwell times, and so they can increase the risk from repeated upward displacement of the diaphragm. They can get protein loss. Apparently the peritoneal membrane is very permeable to plasma proteins. So some of that can be lost in the dialysate fluid. Bleeding, I discussed a little bit earlier. So okay for first few exchanges, blood to pink tinged. After several days can be intraperitoneal bleeding. So especially if it's a new bleeding after the patient has had this patient has had the catheter for a while, and now all of a sudden there's this new bleeding that's coming from nowhere. Then you want to make sure you know it's not an intraperitoneal bleeding. You want to suspect that that's what it is. So you're checking blood pressure and hematocrit. And with the pulmonary complications, some of the other things you can get is the decreased lung expansion. So therefore, you're getting things like atelectasis, pneumonia, or bronchitis. So elevating head or bed, repositioning, and deep breathing is very helpful for the patient. With the protein loss that happens, then you're monitoring their nutrition, making sure they're getting the adequate protein. So peritoneal dialysis is easy to learn. Apparently, you can learn this in like 3 to 7 days. People like it. It's simple. A lot of people like getting it done at home. It increases patient participation. There's no need for special water systems. No need for special equipment setups, none of that, right? It's just literally the pole, the pumps, not the pump, the pole and the, what am I trying to say? For peritoneal dialysis, the pump, and you have a catheter in place, and then just you're connecting the different bags. Essentially, that's all that's happening with the peritoneal dialysis. For hemodialysis, a little bit more complicated. So for sure, you're going to need some type of vascular access site, right? And also for the hemodialysis, the big problem is you need a rapid blood flow and access to a large blood vessel. So you must find vascular access, and that can be hard in some patients. So we can either have the AV fistula, which is our preferred. This is the best one. We're basically connecting an artery to a vein. And because you're connecting the artery to a vein, that increased blood flow from the artery pumps up that site that you've created, makes it bulge. Part of your nursing responsibility is to make sure that it's patent. So when you touch it, it's supposed to feel like you're feeling for a thrill, THRILL, and it feels like little ants walking around underneath that site. And you're also listening for a bruit. When you put your stethoscope there, you hear like this huge whooshing sound. If you do not feel the thrill, so you feel for the thrill, if you don't feel it, and if you do not hear the bruit, then that access is compromised, okay, and you will not be able to use it. So your biggest job is to always make sure that you're assessing the site and that it's good. And the other job is for us to protect that site. So if it's in the arm we're putting up signs in the room saying, you know, no, you're not using that arm for anything, blood pressures, blood draws, making sure everybody can see that. All right. So the AV fistula is our preferred. If whatever reason the artery and the vein do not take, right, it's not working, then they can do a graft. So with a graft, remember, they're using something synthetic. So all they're going to do is they're still going to connect the artery to the vein, but there's going to be a little fake piece there that makes the connection possible so that they can have hemodialysis still happen. If none of this is going to work, then we can do the either the internal jugular or the femoral vein access, because we still have to be able to do the hemodialysis. So preferred is AV fistula, less risks for other things like infections, etc. With a graft, because now you're adding in this foreign thing, potentially it can clot, right? It's this weird thing in the body, so it can clot, infections, those types of things. Same thing with the vascular access as well. Okay, so preferred AV fistula, and then second one is a graft. So fistula allows arterial blood to flow through the vein, and it becomes arterialized. The vein does increase in size, and it becomes very thick. We need it to be thick, because then that we can stick big needles in there, right? So the vein's going to increase in size. We need the wall to be nice and thick, and we need a huge blood flow, like a huge perfusion. We need that huge perfusion push to be able to go through the our machine that's there, our dialysis machine. So we need all that pressure. So you usually need to place this either the fistula or the graft at least 3 months before they need hemodialysis, because it really needs to mature. So remember I said you're feeling for a thrill and you're listening for a bruit. And the bruit is because of the high velocity of the blood flow. So if it's an emergency, right, our fistula is not ready, our graft is not ready, then we are going to use our catheter. And so therefore now you understand that the catheters are primarily temporary. Unless really we can't get fistulas and graft, we do not using catheters for permanent basis. So this is a picture of the AV fistula. All right, so very simple. You are connecting, creating this weird connection between an artery and a vein, right? And your radial artery is shunting arterial blood into a vein. So basically stealing this arterial blood and sending it into a vein, because we need the pressure for that blood to basically go through into the dialysis machine, right? This is part of the mechanism for how the hemodialysis works. You're going to see that later on there's what is known as a steal syndrome that can happen. Well, because that's nice, healthy arterial blood that's basically going to your extremities, right? And now you're stealing it for the purpose of dialysis. So that's why maybe your extremities, like your hand, might hurt or might cramp up, because they're not getting all the blood flow that they would have been getting. So this is just a picture of the connection that's happening here. So this is your vein and this is your artery, and they're making this weird connection. For the graft, as I mentioned, there's some type of synthetic material that's placed. So it's basically a bridge between the artery and a vein. And so this may take anywhere from 2 to 4 weeks. It's more likely to get infected or form clots. And if it's infected, then we may have no choice but to get rid of it. So if the patient has a graft, in some patients, this graft is not going to be as bulging as a regular fistula. And you guys can let me know if that has been your experience as well. So there you go. So normally you would have had the vein connecting to the artery directly, but now we're not doing that. We're bypassing, because for whatever reason we can't connect these two. So now we have to figure this out in a different way. This is our graft that we've created. For the hero graft, so this is one of the newer things that they're doing. For this one, just know that it is out there, but what they're doing is, so if they can't do any of the other ones that I just discussed, there's two pieces that they create over here. There's a tube to bypass whatever blockage, whatever the issue is. So they have a dialysis graft that's basically connected to an artery, and then they also have another, like the graft piece itself basically bypasses the venous system, and then blood flows directly from the target artery to the heart. All right, so I'll show you the picture coming up. So with this one, so they have this whole, the white stuff is the graft piece that they've created, right? So they are actually going to be inserting the needles into this weird white piece that they've created basically. So this is the cannulation area over here, right? So this is their piece. So they've connected this weird thing to the artery here, and then they've taken this directly to the heart, right? So maybe there was a problem with the vein itself. So this is what they've decided to do here. So once again, just know that this one's out there. So once a patient has hemodialysis and they have like a AV fistula or graft, for sure, they can have what is known as distal ischemia. So this is Steele syndrome because too much arterial blood is being shunted or stolen from the distal extremity. So the patient may complain of pain distal to the access site. They may complain of things like numbness or tingling of fingers, and they may have like a poor capillary refill. Some patients can also get aneurysms just because of that pressure between the artery and the vein, and if the pressure is too high, that can actually burst, right? You know what an aneurysm is, so it's a bulging that would happen. So safety alert for AVF and graft, so no BPs, no verni punctures or IV lines, right? Post signs in the room or label the armband, and the biggest thing is preventing infection and clotting. So I already mentioned that when the patient has the catheter insertions, for the most part, they are only for a temporary measure, right? So they can do the interjugular or the femoral vein for this when they need immediate access. And so they can be double lumen. One of the lumens is for blood removal and the other one is for blood return. But still, the one that's removing blood is going into the dialysis machine. And then from the dialysis machine, you have another lumen that's returning the blood. So also high infection risks, dislodgement, and malfunctions with these catheters. So this is what they may look like. So this is a right interjugular placement for a tunneled, cuffed, semi-permanent catheter. So here it is. This is where it starts, and then they have the two ports here. So one would be removing blood, and the other one would be returning blood. So removing blood going to the dialysis machine, and then it would be returning blood back. All right. So very risky because it's right there in the right atrium. So here you go, picture. So long-term cuffed catheters are used when waiting for AVF or other forms have failed. So remember, we do not like using catheters at all. We only use them if we have no other option. So for these types, they'll use upper chest and tunnel to internal external jugular vein. Tip is in the right atrium. One or two cuffs that prevent infection and anchor the catheters. All right, so same thing that I was just talking about. All right, so here's an example of this one. So subclavian. So for the actual hemodialysis itself, for the dialyzers, main thing that you're going to remember is that you have this thousands of parallel hollow tubes of fibers, and you have this semi-permeable membrane. Okay, that's what's making the dialysis exchange happen. So blood is pumped from top into the fibers. Dialysate is pumped from the bottom and bathes the outside of the fibers. So then we've talked about the processes of ultrafiltration, diffusion, and osmosis basically happen. All right. Um, then basically the blood is returned after it's been cleaned. Before hemodialysis, we're assessing things like fluid status, as I mentioned, weight, blood pressure, peripheral edema, heart and lung sounds, the weight from the last post-dialysis and current weight pre-dialysis determine how much fluid will be removed. So all of that is very, very specific. You're assessing the vascular access, assessing the temperature, you're monitoring vital signs every 30 to 60 minutes. So there's a lot of alarms in hemodialysis. Some of it is related to the blood pressure. Some of it is related to the pressures within the machine itself. So the nurses really have to know what they're doing. So these are specialized units. If you are on a floor that has a dialysis room, the patient can be dialyzed on the floor, but you will get the nurse that knows about hemodialysis, right? So the nurses are pretty much like ICU nurses, and they get like special training because things can go bad very, very quickly with this as well. And I think you can understand why. Okay. So the procedure itself, so 2 large bore needles placed in the fistula of the graft. 1 needle is placed to pull blood from circulation to the hemodialysis machine. The other needle is placed to return dialyzed blood to the patient. Heparin is added to prevent clotting. So there's always like a delivery system that's used. So this is what components of a hemodialysis system may look like. So you could follow it basically. So this is from the patient going to the dialyzer. Okay. So then you would get your machine, their fake kidney. So people might call it an artificial kidney. That's the other word that they may use. So you have other components that are bringing in heparin. You have this piece here, the dialysate is coming in from the bottom. So blood coming in from the top, dialysate coming in from the bottom, and then basically the semi-permeable membrane doing its thing, and then blood basically just going back to the patient. So dialyzer blood lines primed with saline solution to eliminate air, terminated by flushing with saline to return all blood to the patient. And then after that, the needles are removed and firm pressure is applied. So you're monitoring the patient's hemoglobin, hematocrit levels, etc. Because with this whole process, sometimes they do lose some blood, and some of it can get left in the machine. So this is why they flush it with normal saline to make sure that all the blood that was cleaned nicely for the patient, that everything is basically returned to the patient. So for hemodialysis, so a lot of it can be in the community-based centers, and depending on the orders, can be anywhere from 3 to 4 hours, 3 days a week. Other schedule options, it's like maybe short daily hemodialysis, long nocturnal hemodialysis, so that's overnight, or home hemodialysis, which I'm really, really surprised that this is even a thing that's happening more frequently now. So this is what home hemodialysis may look like. So think of all the things that I said that could potentially go wrong. So in order for home hemodialysis to definitely work, you need a supportive spouse for sure. My guess is that probably a lot of these people have somebody, probably maybe in the healthcare business, that's comfortable with all the machines and all the alarms that could potentially be going off. So a lot of confidence, a lot of skill is needed for the patient to be at home and getting home hemodialysis. Some of the complications. So things like hypotension, hypovolemia, decreased cardiac output, and some of this can happen because the exchange is happening too quickly, right? So what is the patient going to complain of? So maybe lightheadedness, nausea, seizures. So these are big ones. They're not going to complain of that. They're just going to have a seizure. Vision changes and chest pain. So the treatment is to decrease the volume of fluid removal and administer things like no more saline. So let's say your patient was getting dialyzed and it's supposed to be over 4 hours, and the patient starts complaining of things like feeling cramping or lightheadedness. And there's actually a word for this. I didn't see it in Lewis, but it's known as disequilibrium syndrome. DIS, and then equilibrium syndrome. That's a type of complication that can happen when a patient is getting hemodialysis. And yeah, so imagine you're a regular person at home and this is going on, and now the patient is seizing. Of course, they would have given you training. So in order for you to even qualify to be doing this at home, you have to feel competent that you'd be able to handle any of these complications. But I think it could potentially be very traumatic for somebody if that's the first time it ever happened, right? Um, so here, muscle cramps potentially because of decreased blood pressure, hypovolemia once again, too much ultrafiltration, low sodium dialysate, all of that. So decreasing the rate of ultrafiltration and giving IV fluids could be a potential treatment. So loss of blood, so blood not rinsed from the dialyzer, maybe accidental separation of tubing, dialysis membrane rupturing or bleeding after needles are removed, maybe the patient has too much heparin. So treatment, rinse all the blood, give some of the blood back if you can, avoid excess heparin, and hold pressure basically to the access site. The other thing is that hepatitis C is a big problem. B, not happening so much. So we just want to make sure that the patient has a vaccine, and we're instituting our control parameters. Hemodialysis is not going to replace what the kidneys do. It's going to ease a lot of the symptoms. It can prevent certain complications, like death, basically. If the patient also has cardiovascular disease, though, then we just have to watch them carefully. And if they have any complications, that can complicate everything. So effectiveness, it's very individualized. Some patients will take to it very well, positive about it. Some people may be ambivalent, but for sure a lot of patients are, may be depressed as well. So you want to make sure that your patient has a healthy self-image, and you want to accept the treatment that they're getting, help them accept it, and return them to the highest level of function. So continuous renal replacement therapy. So these are primarily used for treating AKI. So here you're basically trying to get rid of uremic toxins and fluids, similar to hemodialysis, but the main thing, which is in bold for a reason, is that you're doing this slowly and continuously, right? So it's in patients who are hemodynamically unstable, but we have the time to be doing this treatment slowly. So it's not like an emergency situation, because hemodialysis is very quick. So you're trying to do these type of treatment to kind of mimic what the kidneys normally do in a 24-hour period. You can do your CRRT in conjunction with hemodialysis if needed, but for the most part, we're not doing CRRT if the patient has any life-threatening manifestations that require rapid treatment. Just know that there are different types of CRRTs out there depending on how the patient is presenting and what they need. So this is just an example of what a continuous veno-venous therapy may look like. So here, so you can look at it. You don't have to even really memorize this. Just know that this is out here. So let's see what's happening here. So we have an internal or femoral vein over here. So we have our blood that's basically being pumped in. There's a blood pump, right? So we have some of the same things that we're seeing in hemodialysis here, right? And then we're basically getting it back this way after it's been cleaned out. So for the CRRTs, so the replacement fluid determined by degree of fluid and electrolyte imbalance that's needed. Anticoagulants are needed to prevent blood clots, and everything is customized to the patient needs. The other types, so once again, remember I said you don't have to memorize this, but these are the other ones that are using dialysate. Dialysis fluid is attached to the distal end of the hemofilter. Yeah. This page I would like you to kind of pay attention to a little bit more. So I do want you to kind of have a sense of what the differences are between CRRT versus hemodialysis. So main thing is Blood pump is slower than hemodialysis. It's continuous rather than intermittent because they're usually doing this over 24 hours, mimicking the kidneys. So the fluid volume can be removed over days versus hours. The patient therefore has a chance of not getting into trouble as much as they would in hemodialysis. You do not require constant monitoring by the hemodialysis nurse, where, like we said, that hemodialysis nurse is like an ICU nurse and does not require complicated hemodialysis equipment. So it can be continued as long as 30 to 40 days. Hemofilter should be changed every 24 to 48 hours. And one of the other things about CRRT is that they can obtain specimens for serum chemistries. So just like hemodialysis, so specific nursing interventions, you're gaining weight, you're obtaining weight, you're monitoring and documenting lab values, you're doing intake and output, checking vitals, assessing the site for any infection. Just know that this is out there. This is a new thing that they started. So it's recently developed and approved for use. It's a wearable artificial kidney. I do not know anyone who's using this. Please let me know if you do. So apparently it's a miniaturized dialysis machine, 10 pounds, resembles a tube belt. So this is actually amazing. Connects to patient via catheter, designed to filter blood in end-stage renal disease, and can run continuously on batteries. That is pretty amazing. And that is the end. We're now getting into kidney transplants and any of that other stuff.